So what is a decisive moment? A decisive moment is the moment where you show yourself and the world who you really are, what you really value. Not what you like to think you value, not what you'd like to think you believe in, but actually where your revealed preferences, as we've discussed over the last 2 days, become clear to the world. And in healthcare, that's the moment where all of the process questions and all of the institutional questions and all of the competitive questions get stretched aside, and you focus actually on the expression of your core values. And while of course it's true that sometimes those decisive moments are moments that we choose in times of calm or in times of reflection when things are going well, I would say that it's also equally true that decisive moments are often thrust upon us. We don't choose the moment of that cancer diagnosis. We don't choose the moment of the dissolution of your relationship. We don't choose the moment where your institution is under threat. But when those moments present themselves to us, we learn something about who we are and what we believe in. In 1865, a young woman named Emily Stowe applied to be admitted to the School of Medicine at the University of Toronto, where I live. And she received a letter back, and in writing, the vice president of the Toronto School of Medicine said, and I quote, "The doors of our university are not open to women, and I trust that they never will be." I want you to just put yourself in the shoes of that young person for a moment and ask yourself, honestly, what would you do? What would you do if your dreams for your own future had the door slammed in their face in that way? What do you think your response would be? Well, luckily, in that decisive moment, Emily Stowe, I would say, did something much more brave than many of us would do. She packed up her bags, she went to New York, thank you, America. She got her medical training, and then she came home to Toronto, and she opened Women's College Hospital, the first version of which you can see in the right-hand part of that slide. And at the time that she opened her own hospital and started her own nursing school and her own medical college, that building housed 7 beds, 15 doctors, and 1 nurse, and they were all women. It was the first place of its kind in the country, and it has continued to be an organizational trailblazer for women leaders and for women patients in our health system to this day. Fast forward to 1998, when this concrete slab of a building was the next incarnation of a hospital that had become, in many ways, an academic global leader in issues relating to gender and health, was opening the doors to conversations about sex and gender-based analysis in healthcare at a time when actually, in many clinical trials, women weren't even included. And was really blazing a path for leadership locally in the clinical areas, but with a big focus on obstetrics. Most of us, if you talk to anybody in the city of Toronto, somebody was born at Women's College Hospital, including my own child. And so this is a place that was known sort of as a hospital where women went, although we didn't exclusively take care of women. And certainly it was a hospital where women medical leaders were known to grow and build their academic careers. But the politics of the day dictated another decisive moment. The government, our payer at the time, said to us, you know what, there's a lot of duplication of services up and down this hospital corridor in this city. If you want to continue to exist as a hospital, we're going to close all your beds, we're going to close your emergency department, and you're going to become an ambulatory facility. A concept that was completely foreign to the Canadian healthcare system, a concept that most of us had never heard of. So I want you to just think about this for a minute. What do you think it means to be a center of excellence in health for women that doesn't deliver babies? Can you imagine what that could look like? And further to that question, what do you think it means to be an academic health sciences center affiliated with one of the great universities of North America and not have any inpatients? not have access to any of the sickest people, the ones who are strapped to beds in the intensive care unit with, various leads coming out of their body parts. What does it mean to make an academic contribution to scholarship on a global scale when, by necessity, your maximum length of stay as an organization is 18 hours? If you think about the ambulatory hospitals that exist in the US today, most of them tend to serve the healthiest members of the population. They tend to do high volume, low acuity work. Many of them are focused factory models, or many of them will focus on a sort of a polyclinic model of putting a bunch of specialists together in a single organization. But what does the scholarly version of that look like? This is a decisive moment, and yet again, it's one that was thrust upon my organization. And what we decided, after I would say facing some pretty tough existential questions, was that we only had one option, which was to return to our values and to ask ourselves, what would a person who went so far as to start her own hospital and later go on, by the way, to become one of the leaders of the suffragist movement for the women's right to vote in our country, a person who understood that to have a healthy society, you also have to have a just society. What would she have done? And the answer was to look to our community and say, well, we've got an aging population. We have a rise of complex chronic disease. We have patients who increasingly need to be taken care of in their homes and in their communities. We're gonna have to build a completely different kind of hospital. We're gonna have to build a hospital designed to keep people out of hospital. And that is what we became. This is what Women's College Hospital looks like today. It's a custom-built for ambulatory care space, and one of the major areas of focus of our organization is supporting people who live with complex multimorbidity in the community as close to home as possible. And a big way that we do this is by looking to support primary care. We have come to understand as an organization that the most critical relationship, and this is borne out by all the health services literature globally, the most important relationship that a person living with chronic disease has in the healthcare system is their relationship with their primary care provider. And so dumping a whole lot more resources and a whole lot more specialists on top of people is not likely to yield better health for those people. What we need to do is to design programs that support that critical relationship and to think about it in terms of relationship by serving the primary care provider who takes care of that person and knows them best, knows them over time, knows them holistically, and can interact with them around their shared priorities. So what does that look like? Well, you can't quite see it, but just around the corner of the side of that building there is an example of the kind of programming that I'm talking about. It's called our Acute Ambulatory Care Unit. And I always say our AACU is in the location where you would expect to find an emergency department in any other kind of a hospital. But this is not an emergency department. This is a SWAT team of healthcare providers who are there to support family physicians and primary care providers in our community. So I'm a family doc. My office is just across the street from there. And when a patient comes into my office with congestive heart failure exacerbation or chronic lung disease exacerbation or a diagnostic dilemma that I can't quite figure out, it used to be that my only option was to send them to the emergency department. And we've had this conversation over the last 2 days that in fact, in spite of the many differences between our healthcare systems, we have this in common. All roads lead to the emerge. Right? And if you have a situation that you can't manage in a primary care office in a 15-minute visit, basically that's the only place that your patient can go. Instead, today, I pick up the phone and I call what I now call the magic cell phone number. It's magic because it is answered by a physician who wants to help me. And on the other end of the line is an internal medicine specialist who can counsel me and coach me on how I might help that patient in the moment. If necessary, can arrange immediate diagnostic tests. My patient can go over, can have advanced imaging in that unit, and we can send that person home within 4 to 6 hours usually with a home care visit arranged for them later today or tomorrow. That is what the model of the future looks like in an environment where we don't know when people are going to experience exacerbations of their chronic disease, but I can promise you that we know that they will. And so we need to build systems that are not constantly surprised by the fact that people are going to experience those exacerbations, and that build in response mechanisms that do not lead every time to the inpatient bed and to the emergency department. But now we all face another decisive moment, and it's a moment actually that all of us face in this room together. We've been talking a lot over the last 2 days about the rise of technology and the impact, the potential impact of the universe of big data and high tech in our healthcare environments. But we haven't talked very much about the fact that so far, the gains from that technology, both inside healthcare and outside healthcare, have not been evenly distributed across our populations. In fact, very often the solutions that we talk about will be most beneficial to the people in our societies who are not the ones who need healthcare the most. They will not address or integrate the social determinants of health, and they will not reach out to the people who are most vulnerable. And so the decisive moment that we are at now is, how are we going to design incorporation of technology at its highest levels into our healthcare systems in ways that don't leave our most vulnerable community members behind, in ways that are inclusive. Because that's when our values are going to show through, that's when our revealed preferences are going to surface. At Women's College, we're now preparing for that next phase of our evolution. This is the model that we're calling Women's Virtual, our virtual hospital. And as you can see from the model, we're taking everything from the system of referrals to the system of support for self-care and shared decision-making, to the supports that we provide to primary care, home care, and long-term care, to the kinds of virtual services that we all have come to think about, be it a video visit, an asynchronous messaging platform, a telephone consultation between a specialist and a primary care provider. And all of this is about redesigning the model of care that our hospital delivers. In other words, it's not about simply layering technology on top of existing processes. It's not about incorporating tech as a sidebar, a virtual walk-in clinic that's not integrated into your primary care provider's record, or a face-to-face FaceTime type visit with a specialist that doesn't make its way back into your ongoing care plan. Instead, it's about integrating technology in ways that actually become part of the way that we do business. And this is the model that allows us to say, well, what does this mean for new immigrants and refugees arriving in our multicultural city? What does it mean for women? What does it mean for complex elders with complex comorbidity who are living in the high-rise buildings in the center of our city? And how can we make sure that when we build these models, we build them in ways that are more inclusive and that actually give support to those who need it the most? Decisive moments are not always chosen by us, but the way that we respond to them says a lot about who we are and what we believe in. At my organization, we're on a journey of trying to bring technology in service of equity. We believe that it's a worthy mission, and we invite you all to join us. Thank you.